Good afternoon and welcome to this episode of CDA Oasis Live. I'm delighted to welcome back Dr. Keyvan Abbaszadeh, oral maxillofacial surgeon in London, Ontario. And we're going to continue our series of basic oral surgery for general practitioners. And Keyvan, the last day you were here, we did part one of wound closure and suturing, and you revisited the science. Today, we're going to stitch things up, eh?
Yes, we are. All the puns, that's fantastic. Yeah. So thanks again, John, for the opportunity to be with you again and with our colleagues. I really appreciate the chance. And as you mentioned, we're going to stitch things up, and hopefully I won't ramble on. And if I do, you can stitch up lips of mine. That's right. So once again, with your permission, I have a presentation, short presentation that I will share with you. And hopefully it shows up okay.
Perfect. All you have to do is go into the full.
Very good. So part two, and this is again, because the last time was about really the basics of wound closure. We really get to the nitty and gritty of the suturing, and again, I'm not talking about technique in any of these talks. As if you have me later on, we will talk about actual techniques for things, but really just as again, reviews of things, something that we always do. Sutures are really divided into two broad categories: resorbable and non-resorbable. The resorbable ones are the biologic ones. So plain gut suture or chromic gut suture. And they used to be cat gut. And if you talk to some of the older practitioners, and my dad is one of them, he talks about cat gut. It's actually not from cat anymore, it's from sheep gut serosa. And the plain gut has no chemical treatment, so it usually falls apart after about 4 or 5 days, sometimes even sooner if the patients are eating well, drinking well, and their mouth is exposed to chemicals. Chromic gut suture has a surface treatment that makes them last a little bit longer, and they could last anywhere from about 7 days to 2 weeks, sometimes upwards of about 3 weeks. Vicryl is a little bit different, and in the sense that it actually lasts about 4 or 5 weeks and sometimes even longer. The non-resorbable ones, I have silk as one with question mark, because silk being a biologic suture, it actually is resorbable. So if you put silk suture in somebody, they will, over time, it will fall apart. It's just that it lasts for so long that it's considered to be one of the non-resorbable ones. So not one of those ones that you put in and you forget, you need to take it out. Nylon and Gore-Tex are purely synthetic, and they have a lot of applications, not as much intraorally as they should, as elsewhere, because they tend to be uncomfortable. Gore-Tex is softer, but nylon is like a fishing line. So it actually does cause irritation. But the nice thing is that nylon and Gore-Tex are not polyfilaments. They're not wicks. So they can still stay very clean. So that's why my sister-in-law, the periodontist, really likes Gore-Tex and really likes the finer nylon sutures, because the wound stays cleaner. There's not a lot of inflammation. Chromic gut suture, by contrast, not only is polyfilament, it also causes a lot of inflammatory changes. So sometimes that's actually a good thing when we want some scarification to happen at that place. Another way to classify sutures would be by the type of needle that we use. And the needle cross sections you see, there's round or tapered, and then there's the cutting ones. The tapered ones are also called atraumatic, is because they're like a sewing needle. They go through, and as they go, the point is doing all the work, and the needle body doesn't really do anything at all. They're nice because they tend to be atraumatic or less traumatic. The problem with them is that they dull up very quickly. So intraorally, especially when we're working around gingiva, periosteum, bone, and those kind of things, the rounded or the atraumatic ones are not as applicable, but the cutting ones are. The difference between cutting and reverse cutting is that if you look at the reverse cutting, the cutting surface of the needle is the bottom of it. So as this part is going through, the top portion of it is relatively flat. So it actually doesn't cut the tissue closer to the wound edge. So we can grab the tissue without really having a lot of worries about what's going to happen to the wound, and the needle doesn't pull through the tissue. So one practical application is that if you're buying sutures and you're finding that the edges of the incision fall apart or the tear, is because it's probably a cutting suture. So that's something to take a look at if that's something that's you're dealing with. One of the things is about the technique of suturing, and as I said, we'll have more conversations on this and with videos, but really the needle should be kept at right angles to the instrument itself. It should not be at any kind of an acute angle. So in all dimensions, it should be right angles. And grab the needle as close to the eye, but not at the eye of the needle, because it actually could take the thread out of it. And also it helps you not break the edge of it. The other part is that when we're putting the sutures through, we do not want to have our fingers inside the holes of the needle holder. Those holes are not really meant for fingers to be deep inside them. It really should be more like this. And you can see in this picture, my hand is, this thumb or this finger is not even in this hole at all. It's not engaged in the hole. This other one is there just to steady it, and another finger is steadying the body of the needle holder. And in fact, in a lot of cases, if I show you videos of me suturing, sometimes I'm not even having fingers inside it at all. Basically, I'm using just to start, basically, because this has more range of motion than this does. I'm locked in. So you're basically holding it like a pencil and twirling it like a pencil. Again, that's why periodontists like Castroviejos or those fine ophthalmological needle holders, is because they can twirl them like pencils. Principles of it really doesn't change what kind of needle, what kind of suture material we use. All sutures, unless there's a practical application for it, need to enter the tissue at right angles. So we do not come this way, we go in at right angles. What that means is that when you see how the arc of the needle is so long, so wide, that this needle is actually looks like it's saying flush, but really is 90 degrees. If anything, should be slightly more acute. And because when it goes through and it comes through, you see in this picture here, it actually is at right angles. So when it does the right angle turn, we're getting more of the tissue together. We're getting connective tissue to connective tissue and epithelium to epithelium. And one key important thing is that you can see here how the wound edges have been everted. So the wound edges are higher. And what would happen is that we are ensuring that epithelium is against epithelium and connective tissue against connective tissue. Why is that important? Is because epithelium heals faster than connective tissue. So if we get epithelium going underneath the connective tissue, now we end up having a dog ear or uneven edges, something that could have easily been avoided at the time of the suturing. And now we have to go and do scar revisions, which is not pleasant to people. And it could be unsightly, and every procedure has its own ramifications. So really want to emphasize this again, entrance at 90 degrees, exit at 90 degrees, and try to be as equidistant as possible, again, unless there are reasons for it. And this eversion is great. Initially, it looks like we don't know what we're doing, but as this scarring happens, this becomes flat, and it becomes actually more sightly than if you had it perfectly flat. So once again, you see how we're going at right angles, and this we can see what happens is when you go at this angle here, is that now we have less of the tissue caught by the suture. So we actually are catching the entire width here as we go at right angles. We go down, in, out, and equidistant. Knots of the sutures, you can see what one of my former instructors used to call them army of ants, and you have less and less ants as we go up. You can see how the suture is basically more ties here, less here, and less. And the reason for having more throws of suture is that the first one locks the suture in place, and then the following was basically make sure it doesn't get unraveled. The first one usually is 2 throws against the needle holder. Following that, you really don't need multiple, because it really doesn't do anything. And the other ways to suture it would be the ones that I just showed you are interrupted ones, and this is a running and continuous one. And by doing this, this is one needle, one suture that basically closes everything. It's basically kind of like zipping it. It's like a baseball stitch. The benefit of this is that this is pretty quick. The second benefit of it has to do with the fact that this is watertight closure. So when you close it together, there is no leakage, there is no seepage. So if you don't want anything going from here to here, that prevents it, or from here to out, it prevents it. The problem with that also is that because it's watertight, and you have, for example, some ooziness that happens, that oozing has nowhere to go. So patients may develop hematomas and things. So you have to figure out what is the right suture technique for the treatment that we're trying to do. So you can see the needle going through and basically going multiple stitches done with one tie at the beginning and one tie at the end. The disadvantage of this, however, is the fact that it has one suture holding everything in place. Happens to be a very long one, but it's one suture. So something should happen along the way, the entire thing unravels. So if we want to have that watertight closure and a rapid closure, typically applicably what would be helpful would be start off with a running or running locking suture and then do a couple of spot welds along the way with a couple of interrupted ones to basically have knots along. So we have the continuous suture plus the added insurance that we have multiple interrupted ones. Now we're talking about different techniques of suturing, and these horizontal mattress is that you see here. What is happening is that the needle enters with the tissue, goes across, jumps on the side that it came out, goes across, basically parallel with the incision, and then comes out. And when we tie it, we don't actually have any kind of a tie along the incision line. Why is this good? Is because if you're using, for example, a suture like chromic that causes inflammation and we don't want inflammatory changes along the incision edge, we don't have that. We don't get it dirty. The second thing is that because we're using the mattress stitching, we are actually using this bulk of tissue against this bulk of tissue. So if you're dealing with very flimsy tissue that's going to fall apart, this is that 95-year-old lady that has very thin tissue paper tissue, it basically protects it from tearing. Vertical mattress is very similar. If the space is narrow, we can't go across. What we're basically doing is go far and come out far, go in, near, and then come out near. So basically far, far, near, near, and then we tie it in at that end. Similar idea. And so this would be very small, little tiny areas. This is probably my favorite suture for extraction sockets, especially single extractions. So a figure of 8 suture. And what the benefit of this is that it's basically an interrupted locking, running suture. So one suture that closes the whole space. And the way this would go is that you go from mesial lingual to mesial buccal, come out distal lingual to distal buccal. You can go across this way, doesn't matter. But this one actually does make it a figure of 8 or an X-shaped suture. Why is this so good? Why we do it this way rather than going sideways is because as we go across here, we're putting the papilla together here, putting the papilla here together, and the tissue edges come together. And then the fact that X is there, if there's any clot that we want to maintain, we can definitely do that. If you have anything like gel foam or Surgicel for hemostasis, that would keep it in place. Nowadays, we do a lot of socket grafting for pre-implant and pre-prosthetic treatment, and we want that to be maintained. So that's why that X being up there would help it and keeps it together. Like I said, it's very utilitarian suture because it's one suture that holds everything in place. It's relatively clean, relatively quick, and easy to do. And again, there are a couple of neat little tricks when we show, when we actually do this intraoperative things, that we can look at, see how these get done. And then simple interrupted ones is something that we use a lot. So you can see this is one that was on an extraction site. So one suture here, one suture here. Why did I not do a figure of 8 one on this one? Really partly because I wanted to show it. But the other reason for it is because these edges were not really coming together properly. So I didn't want to have any situation that I'm going to distort the tissue or move the keratin and not have enough tissue or tear it. So I decided that I'm going to keep this one and then by itself. But you can see now the central part here doesn't really have much on there. Is that important? Well, not really, because cloth is going to be maintained anyway. But if I wanted to make sure that there's no gel foam that spills out or bone graft material that spills out, at that point, what I would end up doing is maybe put one more suture across just for maintenance of material. And for extraction sites, show the running locking suture, the way what we do is basically do one papilla, jump across, do the next papilla, jump across, and basically what this is a half a figure of 8 or just a slash mark that goes across. Obviously, we can do it this way that doesn't have the suture going across the site. It goes along the side. And but all of this, you can see with one suture, we're closing multiple areas. So the parting slide for me is the purpose of suturing is tissue approximation, not tissue strangulation. So you're not tying the bejeebers out of it and tying it off. What basically we're doing is keeping the tissues together so they don't move apart. There is no floppiness of the tissue and all the other things that we were talking about the last talk. And so it should not, that needs to be secure and firm, but does not need to be tight to the point that you actually get cut off the circulation. So with that, that's the end of this talk. Again, once again, I truly appreciate the opportunity, John. Thank you very much.
Just one tiny little thing. You talked about videos. Do you have some instructional videos that we could?
Yes. So as part of this, with what I was thinking is that because the suturing, this part of it was important to review it, and obviously hopefully we would have some basics of oral surgery. And on purpose, I stayed away from extraction things because that's a completely different issue. But for suturing, yeah, I would be able to show a video of a couple of ones that I already have, and I will work on having more different ones documented as well.
Well, Keyvan, I look forward to your next visit with us. What you're doing here is providing us with, in my view, a world-class resource for practitioners.
Very
I mean it. Thank you profoundly for all your efforts on behalf of our profession.
Thank you very much. Thanks, John.